we're always a little dependent on the internet gods, because it does help us create enormous communication and connections. And I would have never known Rose if it wasn't for the internet. So enough about me. My name is Dr. Tova Goldfein. This is TMS Roundtable Global. We are live on a Monday night. It's 2200, 10 o'clock in Israel. It's, oh my God, very early in the morning. Rose will tell you in a minute, and she'll introduce our amazing guest tonight. Rose, I'm so grateful to you for getting up earlier because the clocks change. What time is it in Melbourne?
No, it's 6 a.m., so it's not that bad.
So bad.
Next week it's 5 a.m.
Okay, wow. We're working on that.
Ladies and gentlemen, we have got two wonderful guests this morning here in Australia, and both of them have got a deep understanding of maternal issues. I say maternal, motherhood issues, and the issues of that ambivalence between being a good mother, in inverted commas, and a real mother, put it that way, because our own expectations of motherhood are often not really what it really is. Actually, have I said it the right way? But they both help mothers to face the reality of being true to themselves and true to their offspring. And both Dr. Carolyn and Dr. Deborah have got a great wealth of information for us all. And, if you think about it, there's a whole lot of guilt, even if you've got a stable sort of relationship and everything's smooth, there's always that guilt because that baby is unrelenting. And how do you manage that unrelenting feeling when you're not feeling supported maybe, or not feeling adequate yourself? So welcome both of you. Please, maybe, I don't know who wants to go first, but just give a brief background maybe of what actually drew you to this area, because it's so important. And the other thing is that Deborah is interested in that social context of how our society wants us to be as mothers, and draw that back to somatic pain and think about the guilt that what our society wants and what we can't deliver then creates guilt. And then through that becomes somatic pain. But enough about me, as Tova said before. Bring in our two guests who are the experts. So thank you both for sharing your time with us. So
welcome.
Would one of you go first and let us know a little bit about your background and etc.
Carolyn, do you want to go first?
Go for it.
Okay. Well, I guess I'll use this segue. Well, thank you for having us. We're really honored to be here. And Rose was talking about my background, looking at the social, historical context of motherhood. So that's kind of how I came at it. When I was in graduate school getting my PhD in psychology, my dissertation research was on bulimia, so eating disorders, and a lot of how we understand the development of eating disorders, especially in psychodynamic theory, is through an attachment lens. And so I was interested in looking at women with bulimia and their relationships with their mothers and their attachment relationship. But as I delve into that, I couldn't help but kind of get into, ways in which we mother have changed over time, historically, and are culturally bound as well. And so I had to sort of recognize that, my participants, for example, who were all bulimic women, I was doing some qualitative research on their experience. Their experience of being mothered was shaped by a particular socio-historical context of mothering and what it means to be a mother, in, late 20th century, early 21st century Western culture, basically. And so I really kind of took a deep dive into some of that work and seeing how ways in which we mother have changed over time, and the ways, since the practices that we engage in when we mother have changed over time, that changes, the ways that we attach to our children, and also the ways that we think about ourselves as mothers, and sort of what we are accepting within ourselves and what maybe we're not accepting within ourselves, which is, I think, kind of what you were talking about, Rose. And just that's socially and historically changeable. It's not always been that way. Hopefully it won't always be that way, but we're in a particular moment of mothering. And I found later, you know, after I'd been a psychologist and practicing a lot, that when I was working with mothers and parents, but especially mothers, when they would start to talk about all their complex mixed feelings towards their kids, they would be really, really nervous to even share any negative or aggressive feelings towards their kids because of a lot of the cultural messages we have today about what it means to be a good mother. You know, that good mothers never get angry, that good mothers never feel ambivalent towards their kids. You know, we can place all those cultural messages, you know, again, like I said, within a particular socio-historical context. So that's kind of how I came at it. And then just doing my clinical work with mothers individually, as I was helping them deconstruct some of those ideas and face their mixed feelings towards their kids, they found it to be incredibly helpful, really powerful interventions. And so I was like, you know, there's something here, and I don't think that there's been enough written about this from a clinical standpoint. And so I wanted to do more with it. And that's how I found Carolyn. And we started doing more with it, basically. So I'll let her take over from there and tell her story.
Yeah, so I'm Carolyn Broudy. I'm a psychiatrist. And I came into this actually as a psychiatrist from a pretty biomedical perspective, just because that's where my training was, you know, and then you know, thinking about the bio, the psycho, and the social, but a lot of it was like kind of from a medical perspective of how to treat postpartum depression and anxiety. And then, you know, working over the last many years with moms and just hearing the stories time and time again, finding the importance of understanding the meaning that's being made of what's happening in the relationship with the child, and how much what we call postpartum depression can often be actually normal feelings, often mixed feelings that come up towards becoming a mother, and then having to grapple with those normal feelings in the context of all of these external judgments and sometimes internal judgments about how it's supposed to be, you know, that we're supposed to love it all.
The label of postpartum depression is like a big stigma.
It's like you have this diagnosis and it's a thing, and now you need a treatment that is, you know, medical. And of course, you know, there is a place for that, just in terms of screening, and sometimes it can be really helpful to use medication. But that in my work with moms, what I've found is that, you know, understanding how shame and guilt play a role in, you know, over having normal mixed feelings and ambivalence about motherhood, and how that can lead to depression, can, you know, and then undoing some of that shame can be really helpful in moms, you know, helping them not feel depressed and not feel anxious anymore.
Yeah. In a way, if you think about it, we're set up to have this perfect, you know, perfect life. You know, we have the right nursery and the right cot and the right this and that and the other, and then the reality of the dirty nappies and the crying and everything. And, you know, the thing is about the guilt. Would you talk about the fact that it's so shaming when, you know, you've got one mother that, you know, delivers her baby and puts on her size 8 jeans, and sort of the other mother doesn't, and then that perception that they're not even socially and you know, then they're not socially sort of up to scratch, you know, and that comparison with one another, and working as a midwife. I mean, it's a long time since I actually was in a postnatal ward, but they'd go in and they'd be talking about what their room was going to be like and what this person was going to do. But the reality is that baby just doesn't stop, and it's unrelenting 24 hours. And the guilt then builds up. And I often wonder how much, you know, we speak to a lot of women with pain, and I'm so aware that it could well be the delivery. And I was speaking to one midwife during the week and telling her about you coming on, and she said, "What about the babies that are delivered by cesarean section? They're not. I'm getting nervous."
Well, the mothers. I could listen to you all night, Rose, but the mothers feel guilty if they go to cesarean as opposed to vaginal.
But the baby is being delivered straight out, and the head isn't being compressed. None of the normal things are happening.
Yeah.
So then the baby comes out in fear, and sits then on the mother. And this is what this midwife who works currently. And at the moment, we have got in Western culture, we have this huge number of cesarean sections that are happening. And it's often the preferred way of delivering your baby these days. So that creates more guilt when the baby is even more unsettled. So I don't know if either of you would sort of address that sort of concept. And then the somatic pain starts. And often it's backache. So in my experience. So
Well, there's a couple things that you mentioned that I think we could speak to. I mean, one is the expectations about what kind of birth you're going to have. And then oftentimes for most people, it doesn't happen that way. And so there's often a lot of shame and guilt about that. And I don't know if Carolyn wants to talk more from a medical perspective about the cesarean versus a vaginal birth. But also the other thing I do want to bookmark and come back to is you're talking about guilt. And when we work with our patients, like we've been doing groups with mothers, we talk about the difference between guilt and self-attack. So I can speak to that also, because we really want to make sure we separate those. But I don't know, Carolyn, if you had something to say about the cesareans or the births or.
Yeah, I guess it's so specific. I mean, there's this idea of, violated expectations, right? Which is like you have this expectation and all these hopes, and then it doesn't go that way. And then you just feel like a failure. You feel like a disappointment. You haven't done what you set out to do, which is, of course, not completely in anyone's control, unfortunately. And so part of what can help kind of empower women in this process of giving birth, which isn't always under our control, is to really find their voice and find a way to feel that at least they are in the moment being kind of included in the process. They're completely aware of what's going on. I find that when women, it sort of ends up like being that it's less about what the outcome is and more about the process. And people feel that they've been respected by the medical, or whoever is involved in helping them have their baby. If they feel included and respected and deferred to, really, then they end up feeling empowered and less disappointed if they feel like they're just sort of shoved along with the
don't you think that, but wouldn't you think, excuse me for interrupting, but wouldn't you think, because what I thought of is the birthing centers started maybe 20 years ago, birthing centers and midwives, because we didn't have, and so it began that it wasn't, because we didn't want to bash the doctors or the birthing ward or the, my own gynecologist who delivered me and delivered my children went out of business because of the legal thing. Like it's not always a pretty profession and a happy profession. And then the midwives came and all the women were excited to have, because there was this feminine, and I'm not going to get racist on here, but this is a very hormonal time. And to have the midwife and someone like Rose talking with you and having this experience and having someone holding your hand, I mean, this is what it came from that. And then, but not everybody can be in a birth center because right. I think that's
everybody can be in a birth center and not everybody can have a doula. But I will say, for anybody who has a history of any kind of trauma, going into having a birth and having a doula, somebody who you can really trust, who's going to be there, who, if you get into this, which often, almost inevitably happens, where you get into a moment where you have to make a decision, you don't know what's happening, and the doula is there by your side and they're helping you communicate, they're then it really can make a huge difference.
It's very popular here, and I know in Europe and it's so popular. The doulas, it's like that. It's like my person.
Yes,
my person.
In New Zealand, you only go to an obstetrician if you've got a problem.
Oh, so really?
All midwife run. Yeah.
Wow, that's amazing.
Yeah.
Right, and it's also very variable depending on like where you are. Because I trained in Manhattan, and then I moved to Western Massachusetts, and here there's lots of birthing centers and doulas, and there it was just like you go to the medical. I mean, of course, there's a lot of variety in Manhattan, but even that there's a lot of cultural differences.
Mm-hmm.
Yeah, within the one country, within the one actually sort of time zone, even. Yes.
Well, and then what's beautiful about this meeting tonight is that we're talking about trying to the big T and the little T, big trauma and little T. We're trying to catch the trauma early on, before the birth, it's like because there will be little traumas and so how do we have the mother, the child, the midwife, the doctor, everyone involved come out with, and so it's about communication, it's about education. And what you are doing now with women, I don't know if you're doing it after they have pregnancy or before. I imagine on all fronts you're able to educate.
Yeah. I mean, I end up seeing, a lot of people who are pregnant and are worried about this. And then we have an opportunity to really talk about how to prepare them. But then I also see a lot of people who end up, having had what felt like what was a traumatic birth. And then they're, of course, struggling because you don't get a break after you have a traumatic birth.
Right.
You go from having a traumatic experience to 24/7 being responsible for a baby. And so,
and not sleeping and hormones out of whack. And there's just no, it's hard enough to process that trauma. And then when are you going to process that? You have a screaming baby, you're not sleeping. So it just all kind of can snowball, even in people that were well prepared, that did have a midwife or a doula. I mean, I do think that those preventative things can really help, but you never know what's going to happen. And, dangerous things can happen during birth, and that can just set off, like I said, this kind of snowball effect. And so then that's when, we work with people after the fact to be able to start to face some of those feelings about what happened, and even towards the baby, because really the baby caused it. I mean, the baby didn't do it on purpose, but, they are the cause of it.
Yeah. Carolyn, would you, on that train, speak a little bit about how, when you ask the mothers how they feel about the baby, what are some of the responses that they give? Because in ISTDP, we usually ask about feelings, and it's a very important sort of type of pressure that brings out unconscious feelings in the person that you're speaking to. So would you mind addressing that? So that our audience can actually get an understanding that it's okay to have whatever feelings you've got, because you don't actually have to act on them, but you have to actually experience them in yourself. So would you just give a little bit of a vignette of it?
I would say on the most common initial reaction to what are the feelings you're having, that come up towards your baby, it's generally like, oh, it's not towards my baby. Right, that's the first response.
Oh,
it's towards the partner, and it's towards the doctor, and it's towards the in-laws, and of course, there's lots of feelings towards all those people as well. But they're also safer, right, to have feelings towards those other people than to feel annoyed with your vulnerable baby, who you also desperately want to protect, and and who needs your protection. So when we talk about, okay, what's it like just to have the feelings? And of course, you don't want to act on these feelings. Of course, you don't want to, in any way harm your baby. But that there's a difference between having a feeling of like, yeah, maybe it's frustrating to have your baby keeping you up. And maybe it's frustrating to have, your baby kind of there for you there when you're having this traumatic experience and actually you need somebody to take care of you, right? That when we talk about, there being a difference between just letting themselves have the feelings and acting on the feelings, that can kind of come as a revelation to many people, like, oh, I can actually have this feeling and still be a good mother and still love my child and still want to take care of my baby and still protect them and not need to protect them from me just having whatever mix of feelings I might have internally.
Could you also elaborate a little bit more about when mothers express those angry feelings towards the baby and about the guilt? Could you just sort of draw it out, almost like a vignette, if you can, of an example, so that we see the whole process sort of like in a couple of minutes, sort of just get an overall view?
Deb, you want to take it? Because you have a recent paper where you do that.
Yeah. So, well, let me actually go back to what we were talking about earlier with guilt, because I want to sort of clarify what we mean when we say guilt, because it often gets confused, because like the mothers we work with, oftentimes when they're talking about guilt or they say guilt, they're really talking about what we end up calling in our groups like mom guilt. And the mom guilt, I think, is what you were talking about earlier, Rose, when you were saying, like, I didn't fit into the size 8 jeans, or I didn't decorate my nursery in the way that it should have looked on social media, or something like that. And so those are when women have these like internal thoughts that they are a bad mother, or they're bad at doing this, right? Bad, like those kind of self-shaming, self-attacking thoughts. And there's no shortage of ammunition for those thoughts. When
there isn't, is there?
others, like you were talking about, when they compare themselves to other people. I mean, social media is a huge magnet for that. You can just like open up, Instagram or Pinterest or something, and there's all these people that are sort of doing it better than you, even though obviously that's very curated. And so right there, you have all these, what I call like weapons of self-attack. And when you start to call yourself a bad mother, or you're not doing it right, it can feel like guilt, but really what it is more like shame and self-attack and getting down on yourself. It's not guilt in the sense of, we teach the mothers about the difference between that self-attack and real like reparative guilt. So we also, as human beings, we have guilt built into us as an adaptive feeling, so that we can live in a just society where we're attached to each other and love each other and support each other, because at times we're going to hurt each other. And we need guilt and a conscience to feel bad about that and to hopefully make amends when we hurt someone we love. And so
this is really important. I'm just going to, because it's a really important topic. And I want to say Dr. David Spector, who is another ISTDP therapist, amazing. I've never heard this before. And because this is important to talk about guilt.
Mm-hmm.
I've never heard a definition it's a signal of your innate goodness. Guilt is the signal of your innate goodness. And you're saying that exact thing. We need this. This is a very important point. We need guilt because...
Right. If we love each other and we're attached to each other, we need guilt to stay attached to each other, because we're inevitably, as we sort of bounce around with each other in relationships, we're going to hurt each other, because humans just conflict with each other. It's just inevitable. Our needs conflict with each other. We get angry or aggressive towards each other. And so we're just going to hurt each other. But because we also love each other, we have this guilt that we can come back together when there's a rupture, and we can make a repair.
Wow.
And in fact, across, developmental psychology in terms of parenting kids, across clinical work, doing psychotherapy, there's so much research and data, like Dr. Tronick's work, showing that ruptures are inevitable. It's the repair that is actually where the golden stuff happens. So we actually need ruptures to happen in our relationships so that we can make the repairs, because the repairs teach us so much about that this relationship can withstand conflict, that we can come back together.
It builds us. It builds our
right. Like we're stronger at the broken places is often like sort of what gets talked about. So we really try to, like with the moms that we work with, help them differentiate between that shaming self-attack, I'm a bad mom because I didn't blah, 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 versus I feel guilty because I did something that may have hurt my child. And that guilt is normal and healthy, and it's healthy for them to feel that. And so what we notice is sometimes rather than face all the mixed feelings towards the child, like maybe the anger or, you know, some aggressive fantasy or something like that, and the guilt that would come with facing that aggressive fantasy, you know, like having this image of, like, for example, I'll give you guys an example. So my friend, a good friend of mine, who's also a clinical psychologist, our sons are 6 months apart. And they're 14. Actually, my son's turning 14 on Friday. And so my friend's son is also 14. And it's funny, they're best friends. They've been best friends since they were babies. But the two moms, myself and my friend, we've been friends since before the kids were born. And one night, the two of us, we had just had our babies. So one was like 1 and one was 6 months old. And we went to a department holiday party. And so we'd had a couple cocktails and we started talking about when the babies were crying and screaming, some of the aggressive fantasies that we had about the baby, you know, to like throw it out the window or something like that. And we both got this look on our face like, wait, you've had that fantasy too? And about like, wow, like, you know, and being psychologists, both of us, we were like, okay, obviously we know that we're not going to act out on that fantasy, that it's normal to have those images kind of pop into your head. But we started talking about like, you know, so many other moms must have these images and fantasies and feel so ashamed about it. And so I think that's what happens is that, or I know that's what happens just from talking to mothers, is that they start to get like a little bit close to maybe some of the aggressive or angry feelings and then immediately back off. And one of the tools they use to back off away from those feelings is to go into that self-attack mechanism. Like, oh, I'm a bad mom. I'm terrible.
Beautiful explanation of what happens to all of us.
Right.
Wow.
Right. So I don't know if that answers your question, Rose, about like sort of what it looks like
It's
when you help
beautiful.
moms face these feelings.
Yeah. Could we also now develop that a little bit deeper and talk about the fact that sometimes we hold guilt and we don't have somewhere to latch it. We've got this aggressive feeling, but the baby isn't acting in a way that draws the aggression in us. Can we just talk a little bit about unconscious anxiety now and unconscious guilt? Because this is what happens in that long-term effect of, you know, you've got a newborn baby, you've got a toddler, and, you know, that feeling is still in us. And then they go into that sort of 5-year-old stage when they want to do their own thing and you want to sort of shake them, but you can't cope with the behavior of the child because of that unconscious guilt. Could we actually draw on that a little bit? I don't know, clinically, do you have sort of like postnatal patients, or are they sort of in that motherhood sort of range of, you know, childhood? What
do you want to take that on, Carolyn?
Sure. Yeah. I mean, you know, it varies. So it's, you know, we have people who come in with infants and then, right, it's a very different, like sometimes the issues that come up with infants are different than the issues that come up in toddlerhood. And right. So that oftentimes in, you know, during infancy, it's sort of what issues or feelings might come up in response to having a really dependent, you know, somebody really depend on you. And the issues of, you know, that come up maybe in toddlerhood, or what it's like to have somebody who's separating and differentiating from you.
Yes, that's what I was trying to sort of say, but I didn't have the right words. Yeah.
Yeah, and so, you know, depending on what might be more, you know, might connect more to your own past, right? That oftentimes, you know, when you have a baby, it reawakens all of those feelings from your own past. Right. So if you had, you know, for instance, if you are somebody who couldn't really depend on somebody as a child and didn't have that sort of dependence and learned that it was weak or shameful to depend, then it may create a lot of anxiety to have an infant. And in fact, you know, it may be that the toddler stage and the older stages are more comfortable for you. You know, if on the other hand, becoming independent and, you know, feeling, you know, differentiated from your, you know, your caretakers as a child might have been something that was difficult for you, then that toddler stage is going to end up bringing up a lot of feelings for you. You know, as your child begins to become more independent, that might create a lot of anxiety. So
could I interrupt there? That in a way, I was reflecting as you were speaking about how somatic pain comes up for people at different periods of their lives. And often when you're speaking to them, you'll ask them what particular event occurred around that time that your somatic pain came up. Now, a lot of people say, well, nothing really. And I want to just draw that back now to the 2-year-old that you can't restrain and the fear that comes up. Because Carolyn sort of brought up a very important subject there, in as much as somatic pain is always connected to a feeling of maybe fear or inadequacy that's actually tied to a particular loved one or a particular incident about a loved one. And, you know, this is a sort of a silent epidemic in a way of where pain comes from. And, you know, when people speak to us, they sort of say, well, we didn't have any trauma. And Tova was saying before about small t trauma and large T trauma. And that's a small t trauma that would be occurring within our society, I suppose. As Carolyn said, you know, that child wants to separate from us and wants to be independent or wants to backchat us. And then in that moment, that inadequacy starts up and the somatic pain occurs. And then it remains until that unconscious guilt about that child is actually released. So, yeah.
And also the unconscious guilt about what it was like for them to separate as a child, right? So it might seem like, oh, I'm not going through anything. This is just a normal stage of development. But then when you end up sort of learning more about, you know, what was this stage like for you as a child, right? Then there might be a lot of feelings that come up. And so this is, you know, once they're experiencing it again with their child, all of that, the guilt about wanting to separate and be independent that might have come up as, you know, in their own life is coming up again here.
Yes, unknown to them.
The patterns are usually similar. It made me think about something that that Rose and I talk about a lot. I lost my train of thought, but what I wanted to do was share with the audience, you know, for example, what does a woman do? Okay, she has the baby, she had the baby, she's going to have the baby. Like, what are some take-home tools? And look, my first thought was, you know how all the moms get a breastfeeding. Okay, why couldn't we? And this is not something, maybe it's already happening, but why couldn't we have someone professional talk to every mother? That comes with the birthing package. Like, can you imagine the mothers getting this kind of help? Like this, and thank God, you know, the word for nurse in Hebrew is also the word for sister. So the nurse is a very important person, and Rose understands that. But if we could do preventative work like this, that would be, you know, or the fact that, you know, the women know their hormones are going to change. We know about oxytocin. We know about prolactin. We know that, you know, sometimes that.
Yeah, but it's a lived experience, Tova, in a way. It's the lived experience. As Carolyn said, you don't even know that you had that trauma when you were 2. You don't even know about it. And then all of a sudden, this guilty feeling comes up. This child is trying to separate out, be independent, and the fear comes up, and then the pain comes with it. So until people start asking, healthcare professionals asking about the feelings about the child, you know, like I've worked in maternal and child health in a mental health situation, and nobody asks the patients about their feelings towards the child. Or, yeah, it's a little while since I've done that. but it was pre my ISTDP training, and it was managing this situation. How are you going to manage when you go home? It's not how do you feel about that baby, or how do you feel about your husband, or how do you feel about your mother-in-law? None of those questions are asked by anyone, unfortunately.
Right.
And well, except maybe Carolyn does, but yeah.
I do.
Like after they've given birth. So I think Tova, you bring up a good point. Like, it would be nice if like maybe the lactation consultant that comes in could also
absolutely.
I'm sure she's a good friend to all the mothers. I'm sure that's a
they are.
The Lanecci ladies and Lanecci League. Do you ladies know about the psychiatrist? Rose met this amazing psychiatrist who teaches psychologists in medical school about ISTDP. Remember the Sweet Sorrow, the gentleman who wrote the book?
Allan Apple, yeah.
Do you know Allan Apple?
The name is familiar, but I don't know him personally.
He's teaching. He's a psychiatrist teaching psychologist in Canada in an institution about this work. So I'm very just also excited to meet a psychiatrist who understands the importance of the mind through these glasses. I'm sure that you're unique, Caroline. Are you unique in your?
Well, actually, she's got a great cohort of other psychiatrists that she.
Yeah.
I think I'm not unique in the ISTDP community.
Okay.
But I think it's the ISTDP community is unique among psychiatrists, right?
Yeah. Yeah. But when I meet the both together, it's like a beautiful divine concert.
Yeah. We've got two lovely ISTDP psychiatrists in Australia.
And isn't Allan Abbass a psychiatrist?
Yes.
And so was Davenlu. Davenlu was a psychiatrist, right?
Yes.
Yeah.
I didn't mean to get you off track. It's very wonderful to know that you're there. I would want to have many mothers know that you ladies exist and you're teaching online. And I mean,
right. And the conversations about a lot of times people come to me and say, I don't know if I want to take medication. And to be able to have a real conversation about that, okay, and how do you have a conversation about that other than just saying, well, you have symptoms, so you should take medication? Well, okay, can we understand whether, it may be that part of the cause is that when you get irritated with your partner or your baby, that what ends up happening is this self-attack thing. And is that something that you want to work on, being able to build the capacity to tolerate those mixed feelings towards that person so that you don't do that self-attack thing, which is what ends up making you feel so depressed? Oh, okay, let me try that. I'll come back to you, in a couple months. And maybe if I need medication then, okay. So then, that's kind of the plan rather than, okay, well, you have symptoms, so therefore let's start you on a medication.
Wow.
Yeah.
Such a refreshing option to give the mother.
Yeah.
Yes. There are a lot of things that we could talk about in this instance. And one of the other things that I want to sort of go back to this cultural expectation and how we were told how we should be. And I want to sort of draw that out a little bit. And, I remember long ago, we used to say to mothers, don't ask your mother about her birthing experience. Just listen to us and don't get involved with that. And as a midwife earlier on, a long, long time ago, one of our readings was Grantley Dick Reed's book. I can't think of the name of it now. And he's a resident in London, and all the midwives were out, so he was sent out for a delivery, and he said to the woman who was sort of like in a shanty place, "Is it painful?" And she said, "Oh, is it supposed to be?" And that set him off to give a really deep understanding that even childbirth is not painful per se, but our society actually tells us it's painful. Amazing. And then we believe it is. So that was a lovely sort of opening as a midwife to actually spend time with patients in labour ward and not concentrate on the pain, but concentrate on the on the feelings that are in the body. I think I was lucky in that regard. So I'm just sort of thinking in terms of that social thing, that this is going to be painful. This child is going to keep you awake all night, and you're going to be put out, and you're going to be miserable for 2 years.
Yeah, it would be nice if people got that sort of primer. Yeah.
Yes.
Yeah.
But the primer that they do get is you're going to be miserable for 2 years. You're going to be sleepless, etc. Yeah. And that expectation, then how that pans out. And then,
I see what you're saying, that they already have that expectation. Right.
Yeah, you're already expecting that this is going to be bad.
Right. Right.
Yeah. So,
right. Yeah.
It's sort of both, right? Like you get both messages culturally, depending. Like some people get the message of like, this is going to put you out for 2 years. And some people get the message of, you know, this is the happiest time of your life. This baby.
Yeah. Very well said. Yes.
And don't wish the time away because you're going to miss it later. And so moms feel guilty, you know, but again, it's more of that mom sort of self-attack guilt when they aren't enjoying, you know, a child who's 18 months old and every day is drudgery to them and, you know, they're not enjoying it and it's not fun. And then they hear messages like, you know, like I just said, like, don't wish the time away. You're going to look back and miss it. And they're like, but I'm not enjoying it. And it's hard for them to, you know, talk about that sometimes because of all of these cultural messages and some, again, things that come up on social media where it's all supposed to be wonderful and fun and exciting. And, you know, for some moms it is, but for not all moms.
I would say like culturally, I think we're allergic to this concept of mixed feelings. You know, that it's that you might have a lot of really positive.
There's negative feelings and positive feelings.
Right. And only one can win out. Like if you either have your positive feelings or your negative feelings. If you have your negative feelings, then that means, you know, they win out over the positive. Or if you have your positive, then you can't let any room for the negative. Right. We're sort of allergic to this idea that, right. And then it creates a lot of anxiety because we're constantly like having to shove part of our feelings aside.
Yeah, it's like they can't exist at the same time.
Could we actually, we can't hold them together. Could we spend a few moments actually thinking about why it is that we blame ourselves and the fact that the neurobiology of our brain makes us, when we look at attachment, blame ourselves when things go wrong. Would one of you address that a little bit more? You know, that self-blame, that self-attack, why it arose and how it can be undone.
You want to take it, Deb?
Yeah, I'll start, but definitely pipe in. I think Carolyn was already talking about that, you know, when it comes to specifically with moms and babies, if you are feeling angry, and then when we feel angry, we have this, you know, these aggressive impulses that also go with anger, that's just, you know, evolutionarily baked into you know, neurologically what happens when we get angry. But at the same time, we are also wired to fiercely protect our offspring when we attach to them. And so if you've got those two feelings at the same time, where you have wired in that you love the baby and you want to protect it, and there's this other part of you that feels like it wants to destroy the baby, so to speak, right? Then what are you going to do with those aggressive feelings? And if you have a hard time, as we were just talking about, holding those two feelings at the same time or in the same space, then what a lot of people sort of the choice they make is to throw themselves under the bus by taking the aggressive feelings and putting them back on themselves in the form of self-attack. And in a way, that's kind of a way to sort of save your baby from them. But by doing so, you're throwing yourself under the bus. And the more you attack yourself with self-critical thoughts like, I'm a bad mom or whatever, the more you're going to get depressed, which ends up then actually causing a lot of problems with the attachment anyway down the line, because a depressed mom has a hard time attaching to her baby. So in a way, I mean, this is all happening unconsciously. It's not like consciously you're thinking through all of these steps. But if the unconscious is trying to protect the baby from the aggressive feelings by attacking the self, and then the self gets depressed because of that self-attack, in the long run, that ends up actually hurting the relationship more. So what Carolyn and I are trying to do through the different clinical interventions that we're developing is to help the moms be able to tolerate having the love and the aggression at the same time, and even the guilt over the aggression, and be able to tolerate those mixed feelings so that they can stay attached to the baby, and then they don't get depressed, and then, you know, they will ultimately have stronger attachment.
Yeah.
Tava, would you put up Edtronic's
beautiful explanation. I just want to I need to compliment Rose, because I've learned so much in these 2 years working with an ISTDP therapist. And Rose, first of all, Rose showed me the Edtronic one, and we sent it to lots of people, and so it's amazing. I'm going to put a note up about it. And then Rose also will bring up occasionally talking to guests about how the mother in the plane puts the mask on her first. And that's what you said. Like, if the mother needs to take care of herself in order to do all these different, unfolding, emotionally important things for the child. And we're pulled, we're in conflict. Child, me, husband, myself. It's, constant conflict going on. And then the conflict runs deep and it creates chronic pain. So it's really, you're bringing things full circle by talking about these things. And I would also like to hear a little bit about some of the classes that you're doing and the groups that you're doing. But Rose, I'm going to just spell the name for me. It's Dr. Ed.
Ed, Tronick.
Yeah, hold on.
Yeah.
And can you explain this video to people, to our listeners, Dr. Ed, like what he's doing? Because you mentioned it twice now. It's such an incredible tool. Edtronic, is that it? Tronik?
ICK.
Can you explain why? And I imagine you show it to all your ladies too. Do you?
We haven't been showing it, but it's definitely influential. I don't know if you want Carolyn to explain it, or Carolyn did some work in his lab.
What's it called? It's called, there's a name. I'm going to give it a name. It's called something. It's the
this baby still face experiment.
Still face, baby still face.
Well, one thing I'll just add to what Deb was saying is that, in order to be able to really hold mixed feelings as a child, right, we need an adult to help us. We can't have positive and negative feelings as a child unless we have an adult who can say, yeah, you're really angry at your brother because he did that thing to you, and and at some level, the implication is, and we know that you still love him, that the anger is okay because you still love him. And so an adult can really help a child to hold their mixed feelings. And when you don't have that as a child, you end up kind of not being able to have the angry parts, and so the anger goes into the self-attack. So part of what you're doing in the groups and in the different work that we're doing is we're saying, okay, so you didn't have that as a child, but that's something you can develop as an adult, is that you can kind of begin to be able to do that for yourself, is to know that even though you're having those really aggressive, angry feelings, that doesn't cancel out the loving feelings.
Yes, as an adult, you can actually repair that, although you never had it. And it's a very difficult thing for patients to actually get that concept. And they'll say to you, well, I never had that as a child. And yes, you didn't. And we can't change that. But what we can change is your concept about yourself. So you notice the self-attack. You notice that every time you have a particular feeling, it goes to self-attack. And that's one of the important things to notice, especially when you've got young children, that self-attack is going to diminish your ability to cope with their mixed feelings, because their mixed feelings, the child's mixed feelings, will bring self-attack into you, and then you back off because you can't cope, and then that Edtronic story comes up. And it doesn't matter if the child's 2 or a newborn, but when you learn, like I've worked with Circle of Security, and it's always being able to remain constant to the child no matter what.
Mhm.
But when our own lives are fractured and we're not aware of it, we're not able to produce that constancy, if that makes sense. Yeah.
Mhm.
We haven't talked very much about somatic pain. How often do patients actually talk to you about their headaches or their backaches and that sort of thing? How often does that happen?
Almost always.
Yeah.
I would say, because and I don't know if you have that slide if you wanted to share it, but one of the things that
Oh, that's right. Yeah.
group
I'll bring it up in a minute. Yeah.
that we're running to help, get moms together so that they're not alone in these feelings, so that they do, it's not just us telling them, well, that's really normal to have those mixed feelings, but it's one another, them actually getting to relate to other mothers who are saying, yes, I feel the same way. Yes, I can relate to that. But one of the things we talk about in the group is that there are different, when we have these mixed feelings, if we have a history of not having anyone there to help us cope with them, then they're going to create a lot of anxiety, and that anxiety manifests in the body in different ways. And sometimes it's just sort of a tension. Oh, well, it's actually the next slide if you want to bring up the other slide that I was referring to. Yeah, okay, there we go, both slides. Right, so the slide on the right is the signs of anxiety in the body and how there's sort of different levels of anxiety, and how, at a low level of anxiety, we tend to experience the anxiety in our voluntary muscles with like tension in our shoulders, sighing, and things like that. And then when anxiety, often caused by the mixed feelings, increases, then it can go into the stomach. Then we have tension in the stomach. We can have migraine headaches. We can feel nauseous, have all these symptoms that are kind of in the yellow zone on that slide. And then when anxiety increases even further, it often can affect our capacity to think and, our cognitive abilities. We may begin to have blurry vision, or just not be able to think, not be able to find words, begin to kind of, disassociate. And that's just, those are the levels of anxiety. Sometimes people go straight to, the red zone. Sometimes they feel themselves going from the green, to then, feeling kind of tense when they're talking about something that's making them anxious, then going to the yellow zone of maybe having some stomach cramps, and then just feeling like I can't really follow what you're talking about, having those cognitive symptoms of anxiety. And again, the triangle of conflict over there is showing that that often what causes this kind of anxiety is when we have these mixed or conflicted or painful feelings, that ends up being what triggers the anxiety. And in order, in order to kind of keep the feelings down, because they're anxiety provoking, we have these different protective mechanisms that we've learned very early in life, such as self-attack, which is one of those, it developed to help protect the child, right? They don't want to have all these really aggressive feelings because they have nobody to help them contain the feelings. So instead they turn it on themselves, and that actually helps them maintain a relationship with their caregiver. The problem is that later in life, when you continue to use that protective mechanism, whenever you're having those mixed feelings, you end up just having a lot of anxiety. And of course, when you're, living chronically with this kind of anxiety, you're going to have a lot of somatic symptoms, a lot of pain. And it's not, in the mind. It's literally that, anxiety will cause the muscles up and cause pain.
And I was going to add to that. Carolyn was talking about it being chronic. And so think about a mom with a baby and or a toddler or both. The kids are so emotionally evocative, and we can't get away from them when they're little, right? I mean, we can maybe with babysitters and daycare and things like that, but a lot of times, we have to be with them. We have to take care of them. We tell our groups, like, before you had a kid, if there was a certain person in your life who was triggering you and causing you a lot of feelings that were then causing you anxiety, you could avoid that person a lot of the time. But with kids, you can't just walk away, especially the little
It's 24/7.
24/7 activating these feelings. And then if you're used to taking the mixed feelings and or if those mixed feelings are causing you a lot of anxiety, and that anxiety tends to get channeled into these somatic pathways, think about how often that's happening. I mean, that's going to happen like hundreds of times during the day, where a child is crying or whining or not listening or whatever, and it's just triggering a feeling that goes to anxiety. And let's say that jumps in the stomach, and you've got IBS or something. And then you can see how it just becomes chronic because it's constant. There's just so many multitude of moments like that throughout the days and weeks and months, especially for moms.
Yeah.
I'm going to load this. These are, I've not seen these slides specifically like this, talking about, the symptoms like in this way. So I'm going to post it on the Facebook page. And I remember doing a course with Hillary Jacobs.
Mm-hmm.
And she would put up some great little articles that I would send to some patients. And one of the things she said was how to deal with anxiety was to separate like the emotions, because I'm just having a little delayed reaction. We were talking about the negative and the positive, and that you might want to separate. Okay, there's the fear, there's the anger, there's the guilt, there's the shame, and somehow that was a way that would calm the brain down. Somehow the brain would calm down.
Mm-hmm.
And I really
that it doesn't have to be one or the other, that you're flipping back and forth. No, I can't feel that way. I have to feel this way. That you can just make room for all of them.
Right.
Yeah.
Because
individually.
It's not like go ahead, Rose.
Sorry. I just, in that concept, can we draw together, as we do in ISTDP, this whole concept of what we've talked about now, that it's something that is within us, that is creating this anxiety as we had those traffic lights, and that we can deal with it. And we can deal with it by, as Tova said, separating it out. Can either of you or both of you actually have a little conversation about that now, so that the people that watch this now will actually, at the end, get a feeling for what they need to do to actually now calm their vasovagal system and settle themselves. So, as we come to an end of our talk.
Yeah, well, one of the reasons we show those slides to the moms is so that they can identify those symptoms first and then kind of work backwards, right? So if I'm getting a stomach upset, then I can think about, okay, my anxiety is really high for some reason. What just happened that triggered my anxiety? And then think about, like, in that situation, who was with me? What was the conflict? What was happening? And what are the feelings I'm having towards that person? Because usually it's something that's happening in a relationship. And so if you're able to really think about those feelings and make some space for those feelings, and even physically feel those feelings and the impulses that go with them in your body, the anxiety should go down. Of course, it's not always that easy, but Carolyn, I don't know if you want to add something to that.
I think that, just knowing, oh, okay, part of the reason I'm feeling this feeling in my gut is because, I'm having mixed feelings towards my child who's crying, or my partner who just left me with my child who's crying, or both, right? Like kind of knowing that, that the reason I have the anxiety is because I both care about these people. I love them.
Said. Yes.
And it's very hard to be irritated and angry at somebody who you really care about. But so when you have that conflict, like, that's going to create this anxiety. Even just kind of identifying that, right?
Yeah.
And be reassuring and can help bring it down. And then, the second part of what Deb was saying is that there is this whole practice of, like, can you then, once you notice the feelings, you notice, okay, I'm irritated and I love them. Can you kind of separate those and one by one, work on allowing yourself to physically let the feeling run through you, And sometimes when you just kind of create a space and let the feeling, the sensations come through you, the anxiety will really come down. But I will say it's kind of a practice.
It's like breathing, conscious breathing, isn't it? You've got to breathe through it. And, like it's the important part of, as we bring our guests together, each guest has a different concept. But one of the important concepts that run right through the whole range is to actually be conscious. Be conscious of your breath, for example. Be conscious that this IBS that's happening to me is not something that's just randomly shot into my gut, but it's got a cause.
Right.
And the cause is a reaction, an inflammatory reaction to some feelings.
Yes.
Inflammatory reaction to whatever feelings they are.
Or what you're,
Tease them out first before you panic. Because panic is another component of this.
And the same way that we're mindful of the anxiety. Okay, I'm aware that this is where the anxiety is. The second part is the mindfulness of the emotions, which I think often gets lost in these conversations about mindfulness. Like it's sort of like all about being mindful of the anxiety and not really like, okay, that's a really important first step, is to be aware and conscious of the anxiety and maybe, calm it down. But then also being mindful of allowing some of the feeling to just run through your body without having to act on it. Sort of a second one.
Yeah. And that's the other fear, isn't it? That if they have this conscious feeling of aggression, that they're going to act on it.
Yes.
Yes. And you see our philosophers in that, and 19th century philosophers, for example, have actually inbred this into our, Hobbes and who's the other one? I can't remember now. But this psyche has sort of happened to us already. And, that's why I want to tell our listeners to actually watch that or find, and I can't remember the name of it, but William Blake, the poet, has written a thing about babies, and I couldn't
You'll
find
think of it tonight. You'll think of it when you go to sleep tonight.
I will, and I'll put it on the side because he actually nailed it, and he was a 19th century poet. So that's just as my final little.
And I'm really happy that Devorah, you shared your interaction with your very good friend about how you felt, because we like to see that, oh, you're a doctor, you don't have those feelings, but every mother has them. Every mother has them.
Yep.
And thank you for bearing your soul here. Many people watch our YouTube, and there's questions that go right to the YouTube, and I usually send it to you. Number one, number two, number three. If people are interested in your groups, can they contact you for that reason as well? Are they online? Are they virtual, your groups?
Yeah, except they would have to be in the states where we're licensed in. So I'm licensed in New York and Carolyn's licensed in Massachusetts. So we don't work across state lines.
And in honor of another amazing ISTDP therapist that came to our show, and I'm learning I must say once a day to a client. I'm so blessed to be involved with some amazing people that Rose brought to the show. So it was Dr. Patricia Coughlin.
Yeah.
And she said that it's helpful, it's to treat yourself like you would treat a newborn baby. And it's kind of like an interesting thing, because it's like, we're so loving, we're so caring, we're so compassionate, we're so gracious, we're besides the feelings of being tired and frustrated, but there's such love. We learn love. And if we could treat ourselves when we're in pain or, going through disease, and, rather than hate, if we could have that connection with ourselves, this is such an important point. She said that, or a little puppy. If you could treat yourself like you treat a new little puppy or your newborn child, this would be, the medicine that we would need to have self-love and self-acceptance. So I would love to bring you ladies back another time, because I always say Rose and I are going to do this for a long time. We appreciate you taking time out in the middle of your days. we are planning on in the next few months to shift sometimes the show to a different time to attract some mothers at nighttime, because it is in the middle of the day in America. And the conversation you brought us was just so interesting.
Thank you for having us. It's great to be here. Yeah.
Yeah, thanks for having us
Thank you
on.
both.
So
Yeah.
take good care and be in
So,
touch with us. And thanks again for your time.
Thanks.
Thank
Have a
you.
wonderful day.
Okay.
Good
Bye.
morning. Good day.
Bye.
Okay. So now I'm
We're
going
off
to just
here.
take the show off and say goodbye.